Hi, my name is John Finoff, and I'll be talking to you about sports ultrasound and specifically elbow pathology. I don't have anything relevant to disclose, but I do have a disclaimer. This presentation is not meant to be a comprehensive review of ultrasound of the entire elbow or the pathology, every type of pathology in the elbow. Rather, its objective is to cover the core competencies as outlined in the AMSSM recommended sports ultrasound curriculum for sports medicine fellowships. So that is specifically what this talk will talk about. With that in mind, I'll go over lateral epicondylopathy, medial epicondylopathy, and dynamic examination of the ulnar nerve. Starting off with the lateral elbow, the common extensor tendon origin is over the lateral epicondylar region. The brachioradialis and the extensor carpi radialis longus originate above the lateral epicondyle, whereas the remaining tendons all originate off of the lateral epicondylar region. The lateral synovial fringe is a plical remnant that is between the capitellum and the underlying radius on the lateral aspect of the elbow. The radial-collateral ligament complex includes the radiocollateral ligament, which comes across from the lateral epicondylar region to the radial head, the annular ligament, which goes around the radial head, and the lateral ulnar collateral ligament, which goes from the lateral epicondyle down to the ulna and attaches and prevents posterolateral rotatory instability of the radial head. It forms the fibers of the radiocollateral ligament, which you can see right here, form the deep 30 to 50% of the common extensor tendon origin region. So if this is the lateral epicondyle right here, and the tendon is from here to about 50% or 70% deep, the remaining 30 to 50% in the deepest portion of these fibers are going to be radiocollateral ligament. And they extend over the top of this radiocapitellar joint and fuse in with the annular ligament. It is very, very difficult to differentiate the radiocollateral ligament from the underlying or overlying extensor tendons. So after I look at these in the long axis and short axis, what I'm really wanting to see is the architecture. It should be fibrillar, hyperechoic. It should be have a homogeneous appearance. The bony origin right in this region here in the long axis, so this is proximal, this is distal, and here is that common extensor tendon origin. The bone should be smooth and there shouldn't be any hyperemia within the tendon. Lateral epicondylopathy will appear hypoechoic. You'll have loss of the normal fibrillar architecture. It will be heterogeneous and thickened, with possible hyperemia, calcifications, and thesophytes and cortical irregularities. So here you can see a calcification in the tendon. You can see the tendon very thick, hypoechoic. You're not seeing that tight fibrillar pattern in this area. Lots of hyperemia in this tendon here. Another thing that's very important is to look for concomitant radiocollateral ligament injuries, because that worsens the prognosis. So if you only have common extensor tendon origin tendinopathy and not a radiocollateral ligament tear, they do better non-operatively. But if they have a significant radiocollateral ligament tear such as this, that person is not going to respond nearly as well to non-operative measures. You also want to differentiate partial thickness tears from full thickness tears. So a partial thickness tear can be superficial, deep, or intrasubstance. And what you'll see is a focal area of fiber discontinuity and decreased volume. So here you can see a partial thickness intrasubstance tear. Here you can see a partial thickness tear that's affecting the radiocollateral ligament and going up into the actual extensor tendon fibers. And here you will see a complete tear of that common extensor tendon origin with complete fiber discontinuity, and frequently these are associated with a hematoma when that's acute. Now moving over towards the medial aspect of the elbow, we're going to look at the common flexor tendon origin. So the flexor pronator tendon is shorter than the common extensor tendon, and it originates off of the medial epicondylar area. The most lateral aspect and the first muscle to arise off of this area is the pronator teres. The tendons in this area will be fibrillar, hyperechoic, homogeneous, without hyperemia. So here you can see that flexor tendon origin off of the medial epicondyle, extending from proximal to distal. The cortex in this region is smooth without any significant irregularities, and there's no hyperemia in this tendon. So in medial epicondylopathy, you're going to see what is typical of tendinopathy. You're going to see hypoechogenicity with loss of the normal fibrillar architecture. It's going to appear heterogeneous and thickened. There might be hyperemia, such as seen in this picture here, with possible calcifications, as you can see in this picture, enthesophytes, and possible cortical irregularities, which you can see cortical irregularities along this cortical margin. You really want to differentiate the tendinopathy from partial or full thickness tears. Here is a partial thickness tear. Again, these can be superficial, intrasubstance, or deep, and they show focal areas of fiber discontinuity and decreased volume, whereas a full thickness tear shows complete disruption of the fibers from the superficial to the deep surface, and again, you can have a hematoma in the area if it's acute. Finally, we'll talk about ulnar nerve instability, and we'll start off with normal ulnar nerve anatomy. The ulnar nerve can be easily identified posterior to the medial epicondyle. So in this picture, here is the medial epicondyle, here is the olecranon process, and here is the ulnar nerve in that region. It's surrounded by perineural fat in the retrocondylar region, and it's held in place by Osborn's fascia. The cubital tunnel is where the ulnar nerve passes underneath the arcuate ligament between the two heads of the flexor carpi ulnaris muscle. So if I scan from proximal to distal in the short axis, here's the ulnar nerve coming behind that medial epicondyle. So here it is by the triceps, here it is coming behind the medial epicondyle. And then here, if I go from behind the medial epicondyle distally, here are the two heads of the flexor carpi ulnaris, and they fuse together. Right there's the arcuate ligament, and here's the muscle coming together. So two heads, arcuate ligament, muscle coming together. So this is the cubital tunnel, whereas over in this area is the retrocondylar groove. So with ulnar nerve instability, it's best imaged in short axis. So here you can see with flexion and extension of the elbow, you can see the ulnar nerve dislocating relative to the medial epicondyle. This is posterior and this is anterior. Here's that ulnar nerve. The transducer is placed over the retrocondylar groove. You really want to float that transducer so you don't have enough pressure in that area to hold the ulnar nerve behind the medial epicondyle. You want it to freely move if it's going to sublux or dislocate. And then you want to flex and extend the elbow. During flexion, it will dislocate, and during extension, it will relocate. You always want to make sure also that there isn't an associated snapping medial head of the triceps. Now, 20% of asymptomatic individuals will have ulnar nerve instability. So just because they have instability in this area does not mean it's pathologic, and it doesn't necessarily need any specific treatment. The nerve can be, if it's affected, it can be hypoechoic and enlarged and have loss of its normal internal architecture. So from a pearls and pitfalls standpoint, be sure the pop is the ulnar nerve. So like I said before, if here's the boom, snap of the ulnar nerve, bam, that second snap right there was the medial head of the triceps. So first snap, second snap. So look for that medial head of the triceps. The other thing you want to look for is an anconeus epitrochlearis. And that is an accessory muscle just like the anconeus, but rather than being over the lateral aspect of the elbow, it's over the medial aspect of the elbow. So here is an anconeus epitrochlearis. So here is the ulnar nerve right here, and here's this accessory muscle. You can see as I scan from proximal to distal, it comes into view and it goes out of view. So that is an anconeus epitrochlearis. Thank you very much for your attention. Here is the bibliography. That completes this presentation.